Thanks. Thank you for that introduction, Mike. And they will come to your home, but they will not bring you food. So, or whatever else Grubhub. I've never ordered from Grubhub. So, all right. Thanks everyone for having me here today. I'm Amanda Gillespie, like Mike said, and I am going to talk about MRSS, otherwise known as Mobile Response and Stabilization Services. So first, I just wanted to give a brief overview of Ohio Rise Services because MRSS is an Ohio Rise service. So this is the umbrella of Ohio Rise Services. We know that care coordination is part of that, where we have limited, moderate, intensive care coordination through our CMEs and Aetna. PRTFs or psychiatric residential treatment facilities are part of Ohio Rise, behavioral health respite, intensive home-based treatment, IHBT, primary flex funds, and then MRSS. So it is part of Ohio Rise Services. However, MRSS is also covered outside of Ohio Rise. So any young person ages 0 to 20 is eligible for MRSS as long as they are presenting in a county that currently has operational MRSS services. So it does not matter the type of insurance coverage the young person has. They could have no insurance and they could still be eligible to receive a mobile response and stabilization services. So it is also covered outside of Ohio Rise. Providers who are providing MRSS in their areas, there is a grant through Aetna that provides funding for this service to those who do not have insurance or who have private insurance. And I did want to share the new MRSS logo. So you will likely see this on new marketing from MRSS teams. It's available in your county through the state. So this is a new logo. It was rebranded to match other state logos with Ohio, the heart of it all. So I wanted to share this, a moment for the logo. And then talk about MRSS and how it is an essential part of Ohio's crisis continuum of care. So MRSS is intended to supplement rather than replace other crisis-related programming for youth and families. So crisis hotlines still exist. We still have our crisis intervention teams. Our walk-in crisis services are still available. We have IHBT, which is part of Ohio's crisis continuum of care, crisis stabilization units, psych units. So MRSS fits within this crisis continuum of care, and it's not replacing any other crisis services that already exist. So it is a structured, community-based, in-person intervention and stabilization service for young people and families provided by certified MRSS teams. So MRSS teams who are providing this service are certified through Ohio MAS licensure and certification. And it can also serve as a gateway to other services across the system of care. So I'll talk about that in a minute. MRSS is grounded in system of care values. So the services that are being provided are individualized to meet the unique needs of the young person and family, and it is really youth guided and family driven. It's strength based, so we're identifying youth and family strengths and incorporating them into the services that we're providing. MRSS has to develop a safety plan with youth and families. So we are incorporating strengths into that, developing an MRSS plan prior to providing stabilization services, incorporating strengths in that. So we're incorporating the strengths of the young person and family in all aspects of the program. It is culturally humble and linguistically competent, so we're incorporating the needs and preferences into services as well. So if the young person and family needs interpretation services, we are making sure that they are getting access to that. Is trauma informed and trauma responsive. So every part of the program incorporates the impact of trauma on the individuals that it's serving. And it's also data driven and outcome oriented. I'm going to talk about this shortly, but MRSS has a data management system that is used by all MRSS providers that is operated by the state. So it does use a lot of data that I will talk about. I wanted to highlight some of the main goals of MRSS. So one of the main goals is to mitigate risk and increase safety for youth and families. We want to provide immediate interventions and supports for youth and families so we can improve the abilities of them of their so we can improve their ability to manage behavior and prevent or effectively manage future crises. We want to prevent or reduce the need for care in more restrictive settings such as inpatient psych units, congregate care, detention centers. So MRSS is an effective and accessible alternative. When families have called law enforcement out to the home, oftentimes law enforcement are calling MRSS to come out and respond in tandem or come out and respond to the crisis instead of, arresting that young person or taking them to the detention home. So it is a great alternative for these more restrictive settings. We want to enhance the resiliency and protective factors of families and facilitate the young person and caregiver's transition to identified supports, resources, and services, which can include evidence-based treatment services, community-based supports, natural resources. So part of that gateway into the system of care. We are coordinating with other service providers. We are identifying resources that the young person and family needs. That includes those natural supports and those community-based services like school-based, outpatient, linking to the local board of DD, linking to food pantries, working with the schools and being part of IEP meetings or 504 meetings. So I'm going to provide as much of a concise overview of the MRSS model as possible. So Ohio's MRSS model incorporates national best practice for youth mobile crisis and is informed by statewide MRSS programs in other states. So Connecticut, New Jersey, Nevada has helped us develop Ohio's model. Again, it's a home and community-based service available to any young person under the age of 21 and their families, as long as the young person is presenting in a county that currently has MRSS. So MRSS is not currently statewide. It is in 55 counties now, operational. There are 2 counties that are working on implementing, and I have a map at the end of the slide deck that you can see which counties currently have operational MRSS. The goal is to get MRSS in all 88 counties with 24/7 availability. Some MRSS teams currently are 24/7, but some are not. So I'll talk about that process in a second. A hallmark of MRSS is that the crisis is defined by the family or the referral source, the caller. So what their definition of a crisis is may differ from what clinicians have historically defined as a crisis. So MRSS operates with a just go approach. A young person, family, referral source are calling, they're requesting MRSS. The triage and screening process is very short because our goal is to go out and respond to that young person and family. Doing a consultation, I do consultation with MRSS teams throughout the state. And one time a provider told me how, a family called, their young person was refusing to eat their chicken nuggets for dinner. So historically, maybe we wouldn't have defined that as a crisis as a clinician. However, the MRSS team responded, went out, and there were more underlying needs. There were more things going on that triggered that young person. They were refusing to eat their chicken nuggets, but that's at the time what the family identified as a crisis. My young person always eats their chicken nuggets, and they're currently not. Something is going on. So the MRSS team went out and responded within 60 minutes to that call. There are 3 phases to MRSS. So the first is the screening and triage phase. And that is when the call comes in requesting MRSS services. And anyone can be a referral source. So we have law enforcement, we have families, we have self-referrals, we have schools that are actually the second highest referral source, followed by parents and guardians. So that call comes in. And national best practice wants one point of access. We do have a statewide call center for MRSS that is 24/7, 365. However, Ohio has a no wrong door policy, so calls do go to the call center to request MRSS services, but calls also go directly to the provider as well. And so there's that screening and triage phase where that call is received. And we want calls to be received consistently, rapidly. So questions are minimal. There are triage questions, but they are minimal just at triaging risk and safety. compassionate and successful. And successful is that we are hanging up that phone and an MRSS team is out immediately within 60 minutes. The second phase immediately follows that screening and triage, which is the mobile response phase. So there is an initial mobile response, and that is when the MRSS team is dispatched to go to the location of the young person. And there's immediate, which is within 60 minutes of that phone call. And then there's also non-immediate, and this is less often, but this is when a young person or family or the referral source is specifically requesting a response time outside of 60 minutes. So maybe a school was a referral source requesting services for the young person, and we get a hold of the parent, and the parent says, well, I have to get off work. I'm leaving work now, but I can't be there in 60 minutes. Can we schedule for later today at 3 p.m.? Okay, that's fine. We'll be out there at 3 p.m. So there could be non-immediate scheduled responses specifically requested by the family, but those have to occur within 48 hours. So if a referral source is calling and saying, we would like MRSS, but can you come out sometime next week? That's not MRSS. They have to be within 48 hours of that referral call. So that's not immediate, but most of them are immediate requests within 60 minutes. And that mobile response phase lasts up to 72 hours, and that is followed by stabilization. But in that mobile response phase and in that initial mobile response, it includes crisis assessment, crisis de-escalation, stabilization services, safety planning. A benchmark of the program is that 90 to 100% of families receiving the service are getting safety planning at that first initial face-to-face meeting. So we are doing safety planning, crisis assessment, and de-escalation. We are also doing the CANs. So CANs is something that MRSS teams are administering to youth and families as well. And then following that mobile response phase is the stabilization phase, which is up to 6 weeks or 42 days from that initial mobile response when the team went out and met with that family and young person face-to-face. Prior to that stabilization phase, they're doing the CANs, and they're also developing or initiating the development of an MRSS plan with youth and family identified goals. Short-term goals that are realistic and achievable within that 6 weeks or 42 days. And just because stabilization is allowable for up to 6 weeks or 42 days doesn't mean that a youth or family are going to need that full 42 days of service. So it really is individualized to meet the needs of the young person and family. So one young person might need just 3 weeks of stabilization, while another young person might need the full 6 weeks. So it's based on the young person's need. During that stabilization phase, they're receiving individualized services, supports, wraparound planning that delivered to meet the unique needs and preferences of each family as identified on that MRSS plan. A lot of MRSS teams have youth or family peer support as well as part of their team. So those are some of the services that are provided to the young person and family are peer support services during that stabilization phase. And then there is a transition. So because it is short term, we are transitioning out. We are developing an individualized transition plan with warm handoff to continuing services and supports or identified services and supports because the MRSS team is making linkages and referrals as well. And they are coordinating, collaborating with the other current systems or providers that are providing services to that young person. I do want to make a note that any young person is eligible to receive stabilization except if they're in IHBT or IHBT similar services. So a young person in IHBT can receive a mobile response. They can, receive that initial mobile response where the MRSS team is going out and doing risk assessment and safety planning, but they're not eligible to receive up to 42 days of stabilization services because the MRSS team is relinking back to that IHBT provider who can then provide that crisis de-escalation and stabilization. IHBT is part of our crisis continuum of care, right? So they can provide those services. So a young person in IHBT, MST, FFT, ACT, they can receive mobile response, but they cannot receive the stabilization because those ongoing providers can do that stabilization, that de-escalation. So I just wanted to add that as, for your information, that they can still receive mobile response, but not the stabilization. I do want to talk about inter-system collaboration because it is an important aspect of MRSS. MRSS teams are using a wraparound approach to planning. They're connecting and collaborating with other services, and that's an essential part. So during that mobile response phase, they're doing risk assessment and safety planning, but they're also working with the youth and family to identify current supports and services that are in place. They're gathering those releases of information, those consents, and then either they're relinking to those services or they're providing stabilization and continuing to collaborate with those ongoing services. So if a young person has an outpatient provider, a school-based provider, MRSS can provide stabilization services, but they're going to be coordinating and collaborating with those ongoing services and supports and having them a part of that ongoing treatment, identifying resources, a part of that CANS, right? Getting those multiple perspectives, a part of that safety plan development. If there are safety plans currently, if a young person has an active safety plan prior to MRSS's involvement, MRSS is going to want to know if there are safety plans and making sure that their safety plan is aligned. MRSS has to develop a safety plan. So we know that other service providers also have to develop a safety plan, like care coordinators. And so this promotes shared responsibility across systems. We're developing collaborative partnerships to assure that services and supports, planning, and linkages are coordinated. We're consulting and coordinating with schools, existing providers. We are doing youth and family meetings and wanting to include those other service providers. If care coordination is involved through Ohio Rise and they're having child and family team meetings, MRSS should also be at that table, of course, with the appropriate consents in place. And then we're transitioning to community-based services and supports because we're short term. There is that transition plan, and we're going to do that warm handoff to those supports. And I know I only have 5 more minutes, so just bear with me. This is the phone number for our MRSS statewide call center that is answered by peer support. It has been operational since summer of 2022. It is 24/7, 365, so you can call at 3 a.m. and someone will answer. And even if that MRSS provider in your county is not 24/7, they will still answer, send that referral to that MRSS team to respond next business day, and then link you to appropriate crisis services that are available, like a hotline or other services in that area. So they do have access to information and services. If someone were to call requesting MRSS, but the MRSS provider wasn't operational during that time. MRSS hours kind of vary by county. Some are 24/7, some are Monday through Friday, 8 to 8, some are 7 days a week from 8 to 10. So on one of the last slides, I have a map that shows, and then you can go to our mrssohio.org website and learn more about like hours of operation. But calling the statewide call center will get you a referral to that MRSS team, whether they're during their mobile hours or not. Again, we have an MRSS data management system, otherwise known as DMS. And so MRSS teams throughout the state are entering data into this data management system, where they are entering outcomes, demographics, information, and a lot of the data is used to help market the program, promote the program. The governor has asked for a lot of data on MRSS. So pretty cool. The MRSS also has family satisfaction interviews that are conducted through BGSU. So Bowling Green State University does the family satisfaction interviews for MRSS teams if the families consent to being part of those. And I did share a little bit of data that the highest referral source are parents and guardians, but that is followed by schools. So schools are the second highest referral source for MRSS. And we also just started collecting data on developmental disabilities. So far, over 10% have had a developmental disability accessing MRSS. This is the map. So currently active in 55 counties, and you can see the counties are with active MRSS have green stars, and those that are in development have yellow stars. So Pike and Athens are currently in development. I believe Athens is aiming to be active in January. And you can see on the left-hand side all the current providers and which counties that they serve. So you'll see some providers have multiple counties. And then one county, Cuyahoga, has two providers. So both Belfair and First Alliance serve Cuyahoga County. That's the only county with two providers. And then again, on the next slide, you'll see the MRSSohio.org website. So you can learn more about MRSS off our website and see contact information for those specific counties. And then these are resources. So Ohio Rise website, if you want to learn more, the MRSSohio.org website, the link to the MRSS rule. MRSS is currently in an RFP process. So they're looking to regionalize MRSS so that it is available in 88 counties with the goal of also being 24/7 availability. So that is something to come within the new year. So just keep that in mind. And MRSS rule through Ohio Mass and ODM is currently being reworked a little bit, but the model overview will essentially be the same. It's just some of the other aspects are going to change a little bit. And that is what I got for you all today.
That was a lot to got.